Myself Dr. Gomati Subramaniam, Head of Department of Radiodiagnosis, Malabar Medical College. Today I am going to tell you a few things which is very important for all the residents, the junior faculties and other faculties, how to interpret a chest X-ray, which is very important because that is the basic investigation for all the patients coming to the department with any clinical scenario. So, as you all know, how do we take a chest X-ray? A patient coming to the department of radiology is taken to the department where there is an X-ray tube. You place the patient to the chest stand. This is the X-ray tube, and the patient stands 6 feet away from the X-ray tube so that we get a good sharp image of the patient to interpret the X-ray. So this is the X-ray tube, this is the patient, and the patient stands with his chest facing the chest stand so that you get a very good image. This is a control panel. Because the lungs are always moving, we give a short time, that's MAS, and we give a KB of 60 to 70, average 60 to 70 kilo patient. Sorry. So that was the conventional X-ray. Now as the imaging modalities and the X-ray tube is coming to newer generation, this is the digital radiography image where this is the ACE monitor and this is the X-ray tube, and you can take the chest X-ray. And after taking the image from the patient, this is come to the desk control panel where we see in the console and we start interpreting. As you all know, the chest X-ray contains the heart, that's the mediastinum, and the lung fields. The lungs appears black on chest X-ray because it contains air, just like a tree and its branches. So how to interpret chest X-ray is mainly by 4 densities, that is the air, the bone, the fat and the soft tissue. And to interpret the hollow structures, we give contrast, that is we give barium for the gastrointestinal system and we give IV contrast to the vasculature. So the air, when too much of air, you can see it becomes black. So air in the lung will appear black, and when there is too much of air, you call it as emphysema. Fluid will appear white. You can see here there is fluid on the left hemithorax which is moderate. Here you can see fluid in the left hemithorax which is severe. So any fluid will appear white on chest X-ray. Fat has got a gray density. So mediastinum has a fat which is normal, and if it becomes abnormal, we call it as a lipoma or a teratoma. So normal fat and abnormal fat can also be interpreted in chest X-ray. The bone. The lung and the heart is protected by the chest cage, the thoracic cage, mainly by the ribs, the clavicle, the sternum anteriorly and the vertebral column posteriorly. Any pathological lesions which contains bone containing structures are called as hamartoma, or there can be pathologies like metastasis which can calcify. A small hamartoma which is calcific densities, large hamartoma, pulmonary hamartoma which is large, called giant hamartoma with calcific densities. So they can appear bony on a chest X-ray. So bone also appears white, but densely white. So I shall show you the lungs with the bronchial tree gets distorted. You call this loss of architecture in severe destructive lung disease, just like in chronic pulmonary fibrosis, or it can in cystic fibrosis where the lung gets destroyed bilaterally. So to learn or interpret chest X-ray, you should know the 12-step program which starts from 1 to 12. All of you should remember. The 1, 2, 3 is a pre-read session which the radiologist has to read, because you should know the name of the patient, the date when the X-ray was taken, and always compare an old film to interpret the recent images. Then the types of views is done by the quality control, mainly by the radiographers and the radiologists who tell how to do it. Mainly the penetration, the inspiration, rotation and the angle is very important to interpret a chest X-ray. The soft tissues, the mediastinum, diaphragm, lung field in a chest X-ray is interpreted by the radiologist, and we have a protocol for that. That is A, B, C, D, E, F, G, H, S mnemonic, which is easy to remember for all when you interpret a chest X-ray. So the basic projections which we take nowadays is only a PA view. AP patients mainly for the sick patients. The apical, the lordotic, decubitus and oblique view has become obsolete now because of the CT, because CT helps to interpret the lung pathologies. So the checklist, as I told you, is A, B, C, D, E, F to know about the pathologies. A stands for air, B stands for bone, C stands for cardiophrenic, costophrenic angles, D for the dome of diaphragm, E for the edge of the heart, F for the lung fields, G for gas bubble, H for the hilum and S for soft tissue. This is very important, so all of you should remember this mnemonic because it will be easy for you to interpret the chest X-ray. So A stands for the trachea, B stands for all the bones, C stands for the cardiophrenic and costophrenic angle, D for the dome of the diaphragm, E for the edge of the heart, F for the lung fields, then H for the hilum, G for the gastric bubble, which is very important, and S for the soft tissue around the bony thoracic wall. So we will come one by one. A, trachea, the air lucency. This is the trachea which should be parallel on either side, and if there is any deviation of the trachea, it indicates a pathology. So here you can see two lesions on either side. It could be a lymph node or it could be a double aortic arch. Here you can see the trachea has been deviated to the left side because there was a volume loss, left lung collapse. Here the trachea is shifted to the right because of the right lung collapse, and sometimes whole of the mediastinum will be shifted to one side when there is absent or hyperplastic pulmonary artery. So the right lung field will be smaller in size in pulmonary hypoplasia. The trachea will be, along with the mediastinum, will be shifted to one side. So the air lucency is very important. Now coming to the pathology. So here you are not seeing the parallel. Here you can see the steeping. So there is infection in the upper trachea, and that is called as the tapering of the trachea in Krupp's. We call it as the steeple sign or wine bottle sign. This is only to show you one pathology of Krupp. Then another pathology which is a hidden pathology is that patient came with respiratory distress to department. Look carefully, you can see one radiopaque density which has been diagnosed to be in the left bronchus. So we could not see it properly, so we took the lateral view. We can see a coin in the left bronchus or at the junction of the trachea and the bronchus. So foreign body ingestion of a coin. So that's the importance of the trachea. Now coming to the bones, all of you should know the bones protective. The lung are mainly the vertebral body, the sternum, the ribs and the clavicle. So you should look carefully whenever you read a chest X-ray, because there can be fracture. As you see the fracture of the clavicle, you can see there can be some pathology in the humerus. Usually you don't take the humerus, but when the patient complains, you have to take it to rule out any pathological lesion. That was an osteochondroma. Here you have an additional bone called as the cervical rib. Then here you can see lot of multiple lytic lesions in the ribs and clavicle, that is the metastasis in a neuroblastoma case. Neuroblastoma. Then you can see severe congenital anomaly, that kyphoscoliosis with butterfly vertebra and hemivertebra. So these are the bony anomaly which you have to look for when you interpret chest X-ray. Coming to the C, that is CP angles, that is the cardiophrenic angle and costophrenic, both should be sharp. It should be sharp. If there is blurring or blunting, it indicates there is some pathology in these angles. So you can see the left CP angle here is blunt, the right cardiophrenic is blunt, indicating a pathology. Mainly white means fluid or cellularity, indicating a mass. So in this case the patient had infection, so it was a case of pneumonia. Or it can be filled with fluid, the CP angle, cardiophrenic, costophrenic obliterated because of the fluid, pleural effusion with air, so air fluid level, so it was a case of hydropneumothorax. Here again the whole of the lung has been collapsed. You can see the blunting of the CP angle because of the air. This is a case of pneumothorax, so spontaneous bulla in a lung caused pneumothorax. Then sometimes patient may go for respiratory distress, the CP angle becomes blunt and goes deep. You get a deep sulcus sign. You can see the pathology, patient has got bronchopneumonia on either side. So that was the CP angle. Now coming to the dome of the diaphragm. We also, it's a teaching that right dome is at a higher level, left dome is at lower level because of the liver on the right side. But now it's teaching is that because of the cardiac pulsation, the left dome comes to a lower level. So always has to check the sharpness of the border Okay, in dextrocardia we have seen that the right dome comes down because of the repeat pulsation of the heart. So check for the free air, gastric bubble and pleural effusion when looking at the dome of the diaphragm. Okay, so now what are you seeing here? You have seen the heart is not seen on the left side, the heart is seen on the right side. This is a case of dextrocardia. You can see the right dome is at lower level, the other dome is at the higher level. So indicating that cardiac is a cause for depression of the dome of the diaphragm. Okay, so this is a case of dextrocardia. So how to study the normal dome of the diaphragm? Draw a line along the summit of the dome of diaphragm, another line from the costo to cardiac phrenic angle, and measure the summit. The dimension will be 1.5. If it is more than 1.5, it indicates elevation of the dome of the diaphragm. So you can see there is elevation of the dome of the diaphragm. There was some pathology. Patient had hepatomegaly causing elevation of the dome of the diaphragm, and the duodenal, there was a perforation duodenum. That's why you can see air under diaphragm, which is called as the pneumoperitoneum. So you have to see the pathology above and below the diaphragm. What is continuous diaphragm sign? When the patient comes with road traffic accident or after positive pressure ventilation, the air enters the mediastinum and you get a pneumomediastinum, and you can see air under the base of the heart, air under the base of the heart, and you can see air surrounding the cardia and in the mediastinum, which is called as pneumomediastinum, pneumopericardium. This is called as the continuous diaphragm sign. This is the pneumoperitoneum, which is a little bit of air surrounding the heart. This is the pneumopericardium and pneumomediastinum. And sometimes you can see too much of air within the lung with air fluid. It's not a lung abscess, but it was a congenital abnormality in the diaphragm, that is in the Bosch-Dalek foramen, called as congenital diaphragmatic hernia. So you can see the bowel loops has come down up from the abdomen, causing scaphoid abdomen. You can see all the bowel are in the chest, which is causing medial shift. So this is an emergency, has to be operated. So the bowel is in the thorax because of the defect in the diaphragm. So the dome of the diaphragm is very important. So you have to see all these structures when you study about the diaphragm. Coming to the edges of the heart, normal cardiac thoracic ratio is 2:1. You take a dimension, the maximum thoracic diameter, and you take the maximum cardiac diameter. Normally is 2:1. Or you can take the diameter of the heart, 2/3 the heart on the right side, 1/3 on the left side. This is how you measure the cardiothoracic ratio. Okay, so coming to the heart, edges of the heart, you have from top to bottom, you have the SVC, you have the ascending aorta, you have the right atrium, then you have the IVC. On the left side, you have the aortic arch, you have the bay, pulmonary bay formed by the pulmonary artery, you have the left atrial appendage, you have the left ventricle. This is the borders of the heart. Always remember that right atrium is on the right side, left ventricle is on the left side, right ventricle is anterior and left atrium is posterior. This always should be remembered. In a chest X-ray, you are seeing only the left ventricle and the right atrium. Okay. So this is a normal mogul, bumps. The first mogul is formed by the aortic arch, the second mogul pulmonary artery, the third mogul is for left atrial appendage, fourth is left ventricle, fifth is the fat in the cardiophrenic angle. So in a lateral view, you are going to see the right ventricle, which is anterior, this is the left ventricle, this is the left ventricle proper, and you have the left atrium. Okay, this is the ascending aorta, the arch, and the descending. This is the retrosternal space, this is the retrocardiac space. So this is the vertebral body. Normally air lucency should be seen in the retrosternal area and in the retrocardiac area. If this becomes white, it indicates a pathology. If there is a pathology in the retrosternal space, it indicates a pathology in the upper lobe or anterior mediastinum. If it becomes white, there is a pathology in the lower lobe or in the posterior mediastinum. Okay, so now what are you seeing here? Whatever I said about the mogul, you are not able to see aortic knuckle, but this becomes parallel. In degenerative disease of the aorta, you get unfolding of the aorta, it becomes parallel. But here you are seeing rounding, isn't it? Here you are seeing rounding. This is the aneurysm of the arch of the aorta. Here you are seeing the aneurysm of the descending thoracic aorta, aneurysm of the arch of the aorta. There is a pathology. Okay. Then here you can see the arch of the aorta is not seen on the left side, you see on the right side. This is a right sided aortic arch. Then coming to the heart proper, normally as I said 2/3 of the heart should be on the right and 1/3 left, but here you see more than 2/3. So this is indicating some abnormality of pathology. So the left ventricle is hypertrophied or dilated. So what you are seeing, you are not able to see the apex is down. So this is left ventricular hypertrophy. When the apex comes upturned, it is right ventricular hypertrophy, which occurs mainly seen in tetralogy or Fallow. Okay, left ventricular hypertrophy you can see in many systemic disorders like hypertension, etc. Here you see more than 1/3 of heart on right side, so right atrium enlarged, isn't it? It comes in Epstein anomaly, mainly where there is right ventricular enlargement or tricuspid regurgitation. Here you can see, normally you don't say left atrium, but left atrium can escape from the vertebral body, sometimes escapes from the right atrium as a double density sign seen retrocardally and cause elevation of the carina. The carina will be widened, which will be seen in case of mitral stenosis. So these are the 4 main pathologies where the chamber enlargement which can be seen in X-ray. Now you can see here both sides more than 2/3 and 1/3. It's not chamber enlargement because you can see the smooth border, pencil border. So this is fluid in the pericardial cavities, case of pericardial elevation, giving the typical jug handle appearance. Again you see the heart has come towards the left side. You are not seeing the heart. There is total medial shift with prominent pulmonary artery. When you look carefully, you can see halo around. Here the pericardium was absent. That's why the lung is interposed with the cardia. Absent pericardium. It's called as congenital pericardial defect. Now coming to the lung field proper, that is F. This is a lung field. You can divide the lung fields into 3 major zones, upper, middle and lower zones, which will help you to divide the pathologies, or you can use the silhouette sign by use of the fissures. Okay, so how to use this? So as I said, this is the upper border which is formed the ascending aorta. So another right heart border mainly formed by the right atrium. This apical border, that is an aortic knob, another criteria. Then left atrial appendage, upper heart border. I'll tell you about the pathologies. Left heart border, mainly by the left ventricle and both diaphragms. So what this stands for? So ascending aorta, if there is any pathology in lung and if the ascending aorta is obliterated, there is a pathology in the upper lobe or in the anterior mediastinum. If there is a pathology hiding the right atrium, you are not able to see the right atrium, it indicates a pathology in the middle lobe or in the middle mediastinum. And if the ascending aorta is obliterated and if the upper left border is obliterated, it indicates pathology in the left upper lobe. If the cardiac border is obliterated, pathology in the lingula. If both diaphragms are obliterated, indicates pathology lower lobe or in the posterior mediastinum. That is called as the silhouette sign. Okay, so this is the showing how it is elevated, showing the pathologies in all the lobe, upper lobe, middle lobe, left upper lobe, lingula and both the diaphragm. So any pathology is hiding the ascending aorta is right upper lobe, that is the right upper margin. Any pathology obliterating the aortic knob and the lingual and the upper border of the ventricle is the left upper lobe. Obliterating the diaphragm is the left lower lobe. Okay, the fissures. You have 2 fissures on the right side. The minor fissure and left oblique fissure. Minor fissures divides upper into middle. Oblique fissure divides the lower lobe into upper and middle. Okay, that is the schematic diagram which is shown. On the left side you have 1 fissure dividing the upper and lower lobes. Okay, so as I told you, the pathologies which divides the fissure, the major oblique fissure separates left upper lobe from left lower lobe. Right major fissure separates right upper middle from the lower lobe. Right minor fissure separates upper from the middle lobe. Okay, so silhouette sign is important sign. Any intrathoracic lesion touching a border of the heart, aorta, diaphragm, you obliterate that border on the X-ray. Okay. So you should know some signs. The silhouette signs mainly for pathology. Air bronchogram sign in a pathology indicates consolidation. Hilum overlay sign indicates that the lesion is anterior or posterior in the mediastinum. Hilum convergence help to differentiate from the pulmonary vessels from a mediastinal mass. Cervicothoracic sign help to differentiate whether the mediastinum lesion is a neck or in the mediastinum. Abdominal thoracic sign helps to differentiate lesion from the thorax and abdomen. incomplete border signs help to define whether the lesion is in the pleura or in the lung. So whenever you define a lesion, you should compartmentalize the lesion to that region. And you should know, to localize the pathology, you should know whether the lesion is intraparenchymal, which shows air bronchogram. If it's a mediastinal lesion, it will has smooth borders and broad base towards the mediastina. If it's a pleura, it will be abutting the chest wall with obtuse angle. If it is extrapleural, always a bony lesion will be bone will be involved. And to describe a lesion in a chest, you should know the lesion descriptors, like you should know it is miliary when it is small lesions, where it can be nodular, or we call it solitary pulmonary nodule when it is miliary, when it is less up to 2 mm. Nodular, it goes to 2 to 5 mm, and you call it a mass when it is more than 3 centimeters, and it becomes a cavity when there is air, and if it has fluid, you call air fluid level. It can be a lung abscess or cavitary metastasis, and it can be reticular when it is thin linear shadows, which you see in pulmonary edema or diffuse interstitial lung disease. And there is a patchy opacity with air bronchum seen in consolidation. And collapse when you have elevation and loss of volume, loss of aeration. Then you have diffuse airspace opacity in pulmonary edema. Okay, so you have liquid densities and increased air densities. It can be generalized or localized. You can see generalized in diffuse alveolar, interstitial or vascular disease. It can be localized when it is infiltrate, consolidation, cavity, mass, congestion, atelectasis, or it can be due to increased air when in chronic obstructive airway disease like in emphysema, or it can be a bulla. Okay, so this you are seeing as a small miliary and nodular shadows. This is miliary pattern which you see in miliary tuberculosis. Nodular, it can be metastasis. This is how you divide the mediastinum by 2 lines along the anterior border of trachea and posterior border of the heart. Another line 1.0 centimeter along the anterior border of the vertebral body, which divides into anterior, middle and posterior to describe the lesions of mediastinum. So I already told you how to describe a lesion in the anterior mediastinal mass. Displace anterior junction line, obliterate a cardiophrenic angle, obliterate retrosternal clear space, high-low overlay sign, and effacement of ascending aorta. So this is a lesion in the anterior mediastinum. There is the thyroid gland coming from the neck. This is the posterior mediastinal lesion going above the clavicle, indicating a lesion in the posterior mediastinum extending to the neck. Middle mediastinum, a widened paracardial stripe, AP window mass, obliterating left SCR reflection, and displays as it goes towards the right. Okay, so this is the lesion showing the paratracheal stripe which has been displaced, and esophageal is displaced. This is a case of middle mediastinal mass lesion. Posterior mediastinal, you should know thoracic sign, widening of the paravertebral stripes. Okay, so here you can see there is a widening here. This is the lesion in the posterior mediastinum. This is actually, according to IMT, it is divided into mainly divided into the visceral space, and the paravertebral space. There is a lot of difference. This is show you the anterior mediastinal mass. This is show you the middle mediastinal mass. This is show you the posterior mediastinal mass. Okay, so this is the pleural, as I told you. If it's a pleural, you get the obtuse angle. If it's extrapleural, you get bone destruction, and this sign is called as the incomplete border sign. And when the CP angle is obliterated, you have pleural effusion. Okay, so always when you read a text, try to see the gas bubble. If you see the gas bubble, it is normal. If there is no gas bubble, indicates achalaeocardia, or it can be a tracheoesophageal fistula also. H stands for the hilum. Always the hilum will be concave, and always sometimes normally the left hilum a little higher level, right hilum lower level is concave, and the bone density should be equal. If it is higher, it indicates a pull from above. If it is lower, pull from below. Okay, so normal dimension of hilum should it mainly formed by the pulmonary vessels. It contains the lymph node, and it also contains veins and some amount of fat. The diameter of the pulmonary vessel is 17. More than 70 indicates some pulmonary hypertension. So here you can see the left hilum is very prominent. The pulmonary artery has become very prominent. Aortic knuckle is very small, so there is blood flow from the left side to the right side. No flood is flowing to the right, that's aorta. That's why the aorta is small. So this was a case of left to right shunt. As reversed, so you have the prominent pulmonary arteries. So it is a ASD with reversal. So here when it becomes pulmonary hypertension becomes severe, you have the upper or lower vessels diverted, and now you can see the upper vessels which is prominent, which is called as a Stag-Lanter sign, and this is the sign to indicate the convexity of the right hilar. Usually it is concave, the hilar angle will be concave. It starts obliterating when there is pulmonary venous hypertension. You can see this grade 1, this grade 2, grade 3. This is this slightly convex, then this becomes more convex. This is really convex coming outside the pulmonary vessels. Then you get the lymph nodes in the hilum. As I said, contents of the hilum is lymph node also, not only vasculature. So you can see a right paratracheal lymph node, bilateral lymph node. This is a case of sarcoidosis. Then coming to the soft tissue, which all of you should know, is mainly the breast, the axillary pad of fat, the neck, the soft tissue which you have to see. So what are soft tissue you are seeing? Here you can see the breast on either side, but this is more denser. Here you are not able to see the breast on the left side, indicating mastectomy, and this is the implants on either side. This is two nipple shadows which should not be considered as a pathology, which always seen in the fifth intercostal space. And this is the muscle, soft tissue, which is extending down to the neck, which should not be confused for a pathology. There is a sternocleidomastoid mastocytosis. Axillary sometimes may extend to the thorax, axillary fold, that should not be considered as a pathology. Then you can see some pathology. Here it is normal, but is more transradial, and you can see some amount of rib narrowing, hyperplasia of the ribs. The case of Poland syndrome, where there is absent pectoralis major, soft tissue. Okay. And you can see some soft tissue densities here indicating lymph node calcific in the old case of tuberculosis. And you can see small rice grain appearance in the soft tissues here, case of cysticercosis. And you can see for patient coming to trauma with plenty of air in the thoracic cage, the neck, pneumomediastinum, this is called as a gingigo leaf sign. Okay, surgical emphysema. Previously in a case of tuberculosis, you have apical tuberculosis was operated. You keep a plumbage so that the patient will not be dysmorphic. This is a thoracoplasty where it is operated, and they have placed a plumbage here in case of apical tuberculosis previously. So what is the cause? Patient developed sudden respiratory distress. So you can see a pneumothorax here, this is normal lung field, pneumothorax here. You can see multiple bullous lesion. You can see thin lesions here, multiple bilateral bullous lesion. So patient coming to you with after jogging, sudden distress. Any finding? It looks normal. Look carefully, you can see a white line above. It's a case of sudden pneumothorax. Okay, then what are you seeing here? This is too much of air here, isn't it? This is a case of emphysema. So what are last but not least, you should know about the hidden areas. Which are the hidden areas which I have marked here? One is the epixis, then the retroclavicular region, then you have the mediastinum and the hilar, then you have the underneath the ribs, then the CP angles and the retrocardiac area are the hidden areas of the chest, which all of you should know. The pathologic will be hidden, so you have to take different views or do a CT. So at the end of the day, you should know how to interpret a chest radiograph and try to identify the structures in a chest radiograph. Thank you.